You do not want your face to show. We do record this, as you just saw, so please go ahead and don't put your cameras on. But if you don't care and you want to show the world, which would be really fabulous, go ahead and do that. We would love to see you. And um, hold on, and I'm letting other people in. Give me 1 second. All right. Okay. Anonymity. If you wish to remain anonymous, please use your first name only. And if you can, let us know in chat. And if you need any resources, let us know. Vaping and smoking, and no vaping and smoking on camera. And then abstinence. While it's not required to attend, please join us sober. If you're under the influence, do not participate. Politics, Sober Livers is nonpartisan. We're about shared experiences with alcohol use disorder, liver diseases, and transplant-related health issues. Secularity, Sober Livers is primarily secular, but we do welcome discussions on spirituality or religion as part of recovery following our feedback guidelines. Pictures and recordings. No pictures or recordings will be allowed during our meeting. I'll say this, except for there is one part where I will allow it, which is when I'm showing QR codes at the end. Late entry, we close the door at the end of the main meeting, 60 minutes before our reflections time. So we will show the information for our buddy system later, but if you're not here, you can't read that anyway. Oh boy, look at what has come up next. So this is our newest meeting that is starting next Wednesday. I'm so excited about it, and I see that our facilitator is here today, Nicole Limo. This is something I have been looking forward to and wanting to do since the start of Sober Livers, which is pet companionship, whether it's a service dog or it's an animal support animal, or you just really love your pets, or you don't have a pet and you really love pets and you want to come and talk, see people talk and share information about their pets. But I will let Nicole briefly say what her mission is because that is all from me. So, Nicole,
Yeah, Jen, were we supposed to see your screen?
do you not see my
At least
screen?
I don't.
Did y'all see my screen?
No, you
Yes.
weren't
No,
sharing
we can't
anything.
see
All
your
we saw
slides.
was you talking and
Oh,
not
okay. Well,
what
you
you
got.
were reading. You wait, yeah.
Okay, I apologize. Now I am sharing my screen.
No, I just was making sure.
Yes, thank you, Nicole. Thank you. I wish somebody would have told me. I would have started sharing my screen. Anyway, oh,
Anyways, yeah.
because this is April, getting close to April Fools. I think this is a perfect start to that. Go
Yeah,
ahead.
that's right. Yeah, so I wanted to I'm a very avid I worked in veterinary med, and I'm a for me it's cats, but that's just me. But my cats were a huge pillar in my liver transplant. Was actually I was listed at about 4:30 a year ago today. And I was on there for about 2 hours, but I we just saw the message from my portal that said to my parents that she's listed and at the highest score possible. So that was a relief to them, but it was really hard for me to be away from them and my cats. And one of them actually, who unfortunately is dealing with her own health issues now, came in. We snuck her in a little bit to see me. So it's just something that it was a huge, pivotal thing in my life and in my um, both transplant and just in alcohol cessation. So I wanted to create a space for people to be able to share about their animals and how it's helped them, because I'm a big proponent of emotional support animals and service animals and all that. So I know we could all talk about our animals forever. When I used to volunteer at hospice, it was as soon as I bring up, I had a cat who all of a sudden they're talking my ear off. So it was something that I know is very therapeutic.
Yes. Oh, thank you, Nicole. And I do too. So hope to see everybody next Wednesday. It's 2 p.m. Eastern time, 11 p or a.m. Pacific time. So put it on your calendars and we'll come and support Nicole with our support animals. Uh, okay. So now I'm so glad you told me because I wanted to make sure that I was sharing my screen when um, put this one up. And now I am sharing my screen, correct? Okay, good. Oops. All right. And let's go to the next slide. So I would like to introduce today somebody who I have been actually kind of following on some of the YouTubes that she's had out. And so I'll quickly introduce Jennifer. So Dr. Flemming, Jen Flemming, so we can get started. And so she is a hepatologist and transplant specialist. She is coming to us from Canada. So thank you for coming all the way and crossing the border and coming down here to Canada for us. We so appreciate it. Thank you to technology so that she could be with us. She cares for patients across the full spectrum of liver diseases. She's a clinician, scientist, and data leader. She leads population-based liver disease research, and she's internationally funded as well. And she is, and I can't read the bottom of my screen here. Let me move it. And she is also in national and international leadership. But I really wanted to, as I mentioned, bring her today because we invited her to be as part of our Whole Health Advisory Council last year, and she graciously accepted. So thank you so much, Dr. Flemming. And I just really love the way she talks to patients in layperson language about the liver and how it works and how your liver works with you. And so with that, I will let you take it away, Dr. Flemming.
Great. Thank you so much, Jen. And thanks everybody for being here today. And I am Canadian and I do live in Canada, but I'm 30 minutes from the New York border. So I'm a little bit closer than you guys might think. So I'm going to share my slides here. Okay, just want to confirm everybody can see that and hear me okay?
Yes.
Okay, so when Jen invited me to speak, we were talking about topics, and she actually came and suggested that we talk about portal hypertension and the complications that you get from that. And I think that that's a really important topic because I think us as physicians, many times when we're speaking to patients, use a lot of the languages, but we don't really explain what it means. And I think once I try and explain this to people, they have a much better understanding about the complications that either they or their loved ones have gone through. And also it helps to understand how the liver can get better over time. So I'm going to spend the next 45 minutes or so talking about portal hypertension, ascites, varices, and hepatic encephalopathy. So what I'm first going to do is I'm just going to actually talk about what the definition of cirrhosis is, because I think a lot of people don't really know what that term actually means. And I'm also going to talk a bit about how we diagnose it and how we actually stage cirrhosis. Then I'm going to talk about how in individuals with cirrhosis, you can develop portal hypertension, and that's kind of a key mechanism that leads to all the complications that patients with liver disease can have, including esophageal varices and variceal bleeding, ascites and spontaneous bacterial peritonitis, hepatorenal syndrome, and hepatic encephalopathy. And just as a bit of a disclaimer here, some of the units that I use here are actually in Canadian metric units. So some of the numbers that you might see here might be different from what you guys are used to. But I can also somewhat translate them for you. I did my transplant training at UCSF, so it was in the United States for 2 years, caring for patients with liver disease. So I have a bit of an understanding of how I can convert the two. And as I spoke with Jen before we started, this is very informal. If anybody would like me to stop and has any questions about any of the slides or concepts that I'm presenting, I'm happy to be interrupted to kind of clarify as we go as well. Okay, so what the actual definition of cirrhosis is, if you look into a medical textbook, it's the end stage of any chronic liver disease. And we say it's characterized histologically. And what we mean by histologically is it's based on a liver biopsy. And in individuals who have a diagnosis of cirrhosis, if you take a liver biopsy, what you would see under the microscope are these big regenerative nodules surrounded by fibrous tissue in the liver. So that is the definition of cirrhosis. But as many of you know, cirrhosis is very heterogeneous. And when we talk in clinical terms, there's kind of two distinct phases that people can transition through. So we use the term compensated cirrhosis for people who, if we did a liver biopsy and we saw these regenerative nodules, but they typically have no symptoms and they may not have any signs of liver failure. And that's in contrast to when somebody develops what we call decompensated cirrhosis, where symptoms and signs of liver failure then start to develop. So the most common causes of cirrhosis, at least in North America, you're probably all very familiar with. There's a new term that we use, a blanket term for steatotic liver disease. And within steatotic liver disease, there's three different phenotypes that we talk about, or three different types of ways that people can have steatotic liver disease. One is what we call MASLD, which is kind of what we used to call non-alcoholic fatty liver disease. The other one is what we now call metabolic ALD, so patients who use alcohol at high levels but also have metabolic risk factors such as diabetes, hypertension, dyslipidemia, high cholesterol. And then there's ALD, alcohol-associated liver disease, where the predominant insult to the liver is related to alcohol. But there's also many other causes. There's viral hepatitis B and C, autoimmune conditions, hereditary conditions. But 90% of all individuals who have a diagnosis of cirrhosis typically would have it due to one of these three main categories. So how does cirrhosis actually develop? So this picture here on the left is a picture of a normal liver where there's no fibrosis. So people have different types of chronic liver diseases, and what happens over time is that there's insult to the liver and inflammation that slowly develops, most of the time without people even knowing, where it gets to the point where your liver starts to repair and try to regenerate itself. One of the amazing things about the liver is it's one of the only organs in the body that can actually repair and fix itself to a certain capacity. And in certain individuals during this repair and regeneration cycle, scar tissue is laid down into the liver. And ultimately, in some individuals, they will develop cirrhosis, which is these big nodules that you see. So on this right side here, you see these nodules on the outside of the liver. We would also see those on liver biopsy. So this is actually some pictures of liver biopsy. And I brought this up because when you're in clinic or you're talking with healthcare professionals, you may have heard these terms used before. So F1, F2, F3, fibrosis. Well, what does that actually mean? Well, this is the progression of how liver fibrosis develops in the liver. So on the first panel here, on the left-hand side, it's F0 or normal. So if we did a biopsy in somebody with no chronic liver disease, this is typically what it would look like. Then as scarring progresses, there's different stages of how this scarring progresses in the liver. So the first step is what we call F1 or periportal fibrosis. So that's where you can see here this blue expansion in the liver, and this is fibrosis tissue that starts to develop, and it typically starts to develop here in the periportal area. As it progresses, we go to F2 fibrosis or septal fibrosis. So that's when the fibrosis starts to expand, not only in around these portal tracts, but it starts to come into the hepatocytes or the liver cells, and you can see that expanding. F3 is what we call bridging fibrosis, and that's when you see these bands of scar tissue that start to link one portal tract to the other. And then over here is what we call F4 fibrosis, which by definition is cirrhosis. And you can see that there's these nodules that start to develop in the liver. So no matter what your chronic liver disease, this process typically occurs over the span of 10 to 30 years. And that's very different depending on the patient, what their underlying liver disease is, and multiple other things. But typically, this is how we understand how scarring progresses in the liver, eventually to develop F4 fibrosis or cirrhosis. But as you all know, people with liver disease don't normally always have liver biopsies, and many of you have probably heard of this transient elastography or FibroScan. And this is a machine that we use in clinic to try and estimate where people are along this spectrum of scarring from F0 to F4, because we can't do a liver biopsy on everybody. There's risks, it's costly, there's potential complications. And so this has kind of really replaced us doing biopsies in many cases to try and estimate the level of scarring. So what happens is you come into the clinic, we use this little probe that's similar to an ultrasound, and what it does is it shoots waves through the liver to judge how stiff it was. Now, the interesting thing about this is that this technology initially was developed by people who make cheese, because apparently if you're a high-end cheese maker, it's very important how stiff your cheese is if you're in cheese competitions. So allegedly, some hepatologists saw this and said, wow, we could actually use this for the liver. And that's actually how it came to be used clinically for patients with liver disease. So when patients come into the clinic, we get a stiffness level based on this FibroScan, and then we can estimate based on how stiff your liver is, where you are from F0, F1, F2, F3, and F4. So these numbers aren't necessarily always exact, but in general, we would say if your liver stiffness is greater than 12.5, we are making an assumption that you're probably on the spectrum of either early cirrhosis or significant fibrosis, and then the levels can go up to as high as 75. So that this is the tool that we use to try and estimate where are people along the spectrum of their liver fibrosis. But once you have cirrhosis, like I said, you can have compensated disease, which is clinically silent. Most of the time, people do not have symptoms. Many people are diagnosed for the very first time with liver disease after they've already developed cirrhosis. But if you're compensated and you don't have any signs of liver failure, the average survival is between 10 to 12 years, again, based on many different factors. However, once you develop decompensated cirrhosis, this is when you develop life-threatening decompensation events, where the average survival dramatically changes to an average of under 3 years. So when I try and explain this in the clinic to people to try and help them understand this concept, I use the analogy of old cars. So I use the analogy that if you have compensated cirrhosis, it's like you have an old car. So there's been slow damage that's built up over time. There may be rust in the car, but if your car is still driving on the road and doing everything that it can, then we need to just take really good care of it. Bring it in for its rust checks. Make sure there's no damage. Whereas decompensated cirrhosis is when the car breaks down. So this old car is trying to truck along and all of a sudden it breaks down. And then the way that we try and describe this in the clinic, and you may have heard of these terms as well, are two different scoring systems. One is called the Child-Pugh score or the CTP score, and the other one is the MELD score. So the Child-Pugh score was initially developed many, many years ago to try and describe, well, in somebody who has cirrhosis, are they compensated and doing very well, or are they on the decompensated spectrum? So this is when we start looking at, does somebody have encephalopathy? Do they have ascites? What's their bilirubin level? What's their INR? What's their albumin? And then what we do is we add up this point system here at the bottom and categorize people as Child-Pugh A, Child-Pugh B, or Child-Pugh C, depending on how many points that they have based on their underlying liver disease. And these are old estimates, but just to show the point that if you have Child-Pugh A cirrhosis, so that would be somebody who has compensated cirrhosis who really doesn't have any signs of liver dysfunction or liver failure. 1 year survival in this group of patients where they studied this was 100%, and 2 year survival was 85. Contrast that to the bottom in somebody who has Child-Pugh cirrhosis, where their 1 year survival now drops down to 45% and 2 year survival to 35%. What you may be more familiar with is a score called the Model for End-Stage Liver Disease, or the MELD score. And this is a score that ranges from 6 to 40. And instead of trying to estimate how likely is somebody going to die from their liver disease in 1 or 2 years, this is trying to estimate how likely this will happen within a 3-month period. So this is why this score is more so used for liver transplant prioritization, because it gives us a better estimate in the short term of how likely you are to die from your liver disease. So this is where we use the bilirubin, the creatinine, the INR, and the sodium to make this calculation. Now, there has been a recent update to the MELD score. It's called the MELD 3.0. Again, you may have heard of this because this is actually now used in the United States for prioritization for liver transplantation. And what they did with MELD 3.0 is they included sex as a variable because there was a clear disparity in the ability for females to access liver transplantation, in part due to the creatinine level, because the creatinine level, which is the measure of your kidney function, relates to the amount of muscle mass that you have. And in general, females have less muscle mass. And so what this score has done is tried to allow females to access liver transplant in a similar rate to their male counterparts. So when we look at the MELD score, we can see that on the bottom here is what the MELD score actually is. So it ranges from 10 usually to 40. And this is the 3-month patient survival. So you can see when your MELD score is relatively low, below 10, chances are you're going to be fine in the next 3 months. The score of 15 is where the risk benefit tips towards liver transplantation, where the risk of you having complications or dying from your liver disease is high enough, where the risk of undergoing a transplantation, which is a big surgery, which also has potential complications, that's where it tips. And so typically in most transplant programs, we'll start to be thinking about should somebody be listed or thinking about a liver transplant once their MELD score reaches 15. Okay, so any questions about that? Everyone's good with that? Okay. So the next part of the talk is talking about the natural history of chronic liver diseases. So on the left-hand side, you have a chronic liver disease that progresses over time. In a certain subset of people, you'll develop compensated cirrhosis. And on average, if you took 100 patients who had compensated cirrhosis in 1 year, 5 of them would develop a decompensation event, and then that would put them at risk of dying from their underlying liver disease. And when we talk about decompensation events, we typically are talking about having a variceal hemorrhage. You develop ascites, you develop hepatic encephalopathy, hepatocellular carcinoma, which is liver cancer, or hepatorenal syndrome. But as I mentioned, because the liver is such an amazing organ, there is the ability to go back and forth between being compensated and decompensated. So typically, in order to go from a decompensated state back to a compensated state, you need to treat the underlying cause of what's causing the liver disease. So in the instance of ALD, it's really alcohol abstinence or harm reduction. For viral hepatitis, we treat their underlying hepatitis B and C. If you have autoimmune hepatitis, we can give steroids. And this is a concept that's really developed in the liver world about what we call cirrhosis recompensation. So that's when we take our old car that has been broken down, we bring it into the shop, we try and fix it, and we try and get it back on the road. So this is the concept of cirrhosis recompensation. If you look at the actual definition of people in the literature who write about this, there's 3 main things that we use to define whether or not somebody has developed cirrhosis recompensation. The first is, have we controlled or cured their underlying liver disease etiology? So in ALD, have we achieved alcohol abstinence? For viral hepatitis, have we either treated or cured their virus? And for metabolic associated liver disease, have we gotten weight loss? Are we eating better? Are we exercising? The second thing is that there's no signs of decompensation events off all medical therapy for 12 months. The third is, in conjunction with this, we're seeing improvements in your liver tests and your MELD scores getting better over time. So this is a concept that we are seeing more and more, especially in the setting of ALD, because of the amazing regenerative capacity of the liver. Okay. So the next part of the talk is where I'm going to go into, well, what actually is portal hypertension and how does it develop and why does it cause the complications that we see with liver disease? So first,
Can I stop you right there? Because I
yeah.
also want to say that it's also because of the people who are doing the regenerating too. So they're regenerating as well. So it's not just your liver that's getting the
No, it's the
regeneration.
whole body, actually.
Yeah.
Yeah. The
So
whole body is just
the
repairing
people
itself.
who have to, yeah. So yes, so thank you. Go
Okay.
ahead.
So I want to make sure everybody understands about the blood flow to the liver because this is a key concept to help you understand why all of these complications happen. So the portal venous system is a blood system that really connects your GI tract, so your bowels and your stomach, to your liver. It's not connected to your peripheral blood system. So the arteries in your arms, your heart, everything, that's a completely separate blood system and the two are connected through the liver. So what we see here is the portal vein, and these are your bowels here. This is your spleen here. And so what happens is all the blood that drains from these organs comes up through the portal vein, comes up into the liver. The liver then does all of its magical things with the blood that it's receiving, and then that blood is then put into the heart, and then the heart pumps it around the rest of the body. Okay? So this is kind of a key concept to understand because it will help you understand why people develop a lot of the complications that they do. Okay. So this is a picture of what we would see under a microscope if we looked really, really closely into the architecture of the liver. So what this thing here in the middle is, it's basically a tube. It's called the hepatic sinusoid. And what this area of the liver is this is where the blood from the portal vein drains into the liver. So this is the blood that's coming up from the bowels. It drains into the liver and it goes into these sinusoids. Sitting right next to these sinusoids, these big red squares, those are the hepatocytes. So those are the cells of your liver that do all your detoxifying, they do all your metabolism, they produce all your proteins. And in between the hepatocyte and the sinusoid, there's this space called the space of Dis. It's written right there. So there's this tiny little space here in between the liver cell and the blood vessel where these cells called hepatic stellate cells live. So normally what hepatic stellate cells do is they store your vitamin A. But what happens when there's a chronic liver injury is that these hepatic stellate cells get activated, and that's where the fibrosis starts to get deposited. So all of a sudden, instead of having a small space in between the hepatocyte and the sinusoid, it starts to get expanded because these cells are laying down fibrous tissue that's expanding the space between this hepatocyte and this sinusoid or blood vessel. And over time, that's how cirrhosis develops. That's where the fibrous tissue is being deposited, and it causes distortion of the whole architecture of the liver. So I'm going to use a real world example to try and make this point more clear. So I'm using this example of a city, and I'm also going to be using it in respect to having a snowstorm. So I'm Canadian. I've been through a lot of snowstorms this winter. It's been a really bad winter, but I think it helps to understand the concept of how portal hypertension develops. So if we say this is normal liver histology, or if we were looking under the microscope of a normal liver, this is what we would see. So the houses and the offices of the city are the hepatocytes. Those are the ones that are doing all the work and doing all the cleaning and production and everything in the liver. The streets are your sinusoids. So those are where the blood is flowing next to those hepatocytes. The sidewalks are the space of Dis, that small space where that hepatic stellate cell lives. And the cars are the portal blood flow that's flowing through those sinusoids. So when there's no fibrosis and no scarring in the liver, there's very low resistance to flow and the traffic moves easily through the city. and the city is functioning very well. What happens when there's a snowstorm? So either there's alcohol involvement, MASLD, viral hepatitis. What happens is there's a snowstorm that's developing in your liver, and then it can lead to the development of compensated cirrhosis. So this is when the snow starts getting deposited on the sidewalks. So for anybody who has lived in winter, you can understand that after there's a snowstorm and the snow plows come through, they push all the snow onto the sidewalks and it makes the streets very narrow. And it makes it very hard for traffic to get through the streets because the sidewalks are expanded from all the snow. So that means that there's narrowing of the streets. So when there's narrowing of the streets, the houses and the offices are okay. So it's not actually affecting the hepatocytes right now. So they're still functioning well. So that's why in compensated cirrhosis, even though there has been damage that's done to the liver, it's actually functioning okay. But what starts to happen is the traffic starts to back up. And so what I mean by that is the blood that's trying to flow from the portal vein into the liver starts to meet this resistance to flow because those sinusoids are narrowed and it's much harder for the blood to flow through. And when that happens, the pressure in those sinusoids starts to go up. Okay, so you can see here there's much more traffic around and much more congestion that's going on. If the snowstorm doesn't stop, so if there's continued exposure to alcohol, metabolic risk factors, the viral hepatitis isn't treated, then this fibrosis tissue continues and continues to build up to the point where it actually starts to cause dysfunction of the hepatocytes or the houses and the offices. And when the houses and the offices start to go down, that's when other aspects of liver failure start to develop as well. So you're not producing your proteins, you're not producing your clotting factors, you're not filtering your blood. The sinusoids, the traffic gets heavier and heavier. There's this pressure that's building and building because the blood is not able to flow through those sinusoids. And then the city starts to fail. It can't sustain the function if there's ongoing insults and buildup of this snow or this fibrosis that's going on. But if the snowstorm stops, so if alcohol abstinence is able to be achieved, weight loss, treatment of underlying liver diseases, then the snow plows come in and then your liver can start to resorb some of this fibrous tissue that's been deposited on these sidewalks or on these space of discs. And then what happens is once that happens, the sinusoids start to open up, the traffic starts to move easier, the pressure starts to go down, and then the city can start to function better. So this is how I try and convey the concept of how portal hypertension can develop and how it can get better when you can treat the underlying liver disease. But the city will begin to regain function. But if another snowstorm hits, then it may not be able to recover. So this is the concept of we can go back and forth between having decompensated cirrhosis and compensated cirrhosis. But there comes a point in time where there's been so much damage to the liver that your liver is unable to repair and regenerate itself. And liver failure continues despite all of your best efforts. And that's when typically we start thinking about liver transplantation. Is there any questions about this concept?
We have a question in chat. Nancy, I
Yep.
don't know if you saw that
I
or
can't
not.
see it. Maybe if you can read it out to me.
No, I'll read it for you. What is happening when you have a clot in the portal vein?
So when you have a clot in the portal vein, the blood is not getting from the bowels into the liver. Okay, so it's creating more resistance to flow because that blood is trying to flow up from the portal vein into the liver. And so if there's a blood clot, it's like it's a big traffic jam and nothing can get through. So the problem when that happens is that your liver doesn't get enough blood flow. And so that can worsen the function of the liver because your liver needs the blood in order to try and regenerate itself. So that's why the portal hypertension increases even further because it's a major traffic jam on a major highway that's going into the liver. Does that help clarify? Okay. All right. So This is why the complications of cirrhosis result from portal hypertension, which is the high pressures that have developed in the liver, but also from what we call hepatocyte insufficiency, or the inability of the offices and the houses to function in the liver. So when you have portal hypertension, which is narrowing and high pressure in the sinusoids, this is what predisposes people to developing variceal bleeding as well as ascites. And once you have ascites, you can be at risk of developing spontaneous bacterial peritonitis and hepatorenal syndrome. Similarly, when you have liver insufficiency or problems with the hepatocytes and they're being damaged, this can precipitate hepatic encephalopathy and other signs of liver failure, such as the inability to produce proteins, as well as clotting factors and other important things that your body needs. So I'm going to go through each one of these complications and kind of relate it back to the concept of portal hypertension. So why do people get esophageal and gastric varices? So again, this is a picture of the portal blood flow. So here's the portal vein. It's trying to go up through the liver, but the liver is all scarred and narrowed and there's a big traffic jam going on in there. So what happens when there's a big traffic jam? The blood flow follows the path of least resistance. So when it's too hard to go through the liver because there's a traffic jam, the blood says, okay, I'm going to start going this way. One of the first places it goes is the splenic vein. This is why your spleen gets big, because the blood's all diverting there. And because your spleen's like a big sponge, all of a sudden it starts to get big, 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 big. And then all your platelets hide in there. The other place that it can go is through the gastric vein and up through these veins of the stomach around the end of the esophagus. And this is where we see gastroesophageal varices. So varices are a consequence of portal hypertension. And when I try and explain this to people, it's like balloons, okay? So you have veins that are in your esophagus and your stomach, which without portal hypertension, they're floppy. But when people have portal hypertension and all this blood is now diverting from the liver and going into these veins, then this balloon is expanding, okay? And once the pressure within that vein reaches a critical point, it pops. Okay, so that's why people develop variceal bleeding, because the pressure is building up inside that vein to the point where the vein cannot sustain itself and it pops and then it starts bleeding. So when we look endoscopically at what varices look like, on the left-hand side, this is a normal esophagus. This is where your esophagus connects to your stomach. You don't see any big veins down here. So this is what we would see very often when we're doing endoscopy. And somebody who has varices, you start seeing these veins that are starting to fill up with blood. These ones we would say are relatively small if they occupy less than 1/3 of the whole diameter of the esophagus. But as the pressure builds and builds and builds, then these veins get bigger and bigger and bigger as the pressure rises. When we look at them with our endoscope, you may have heard the term red whale marks. So that's when we look at varices with our endoscopy and we see these red patches here. And what that is you can imagine if you have a balloon and the pressure is getting higher and higher and the wall of the balloon is getting thinner and thinner, you're going to be able to see through it. So this is actually because the wall of that varice is stretched under pressure and you can start to see the blood underneath. So whenever we see that, we know that they're under high pressure and that they're at higher risk of bleeding. And certainly when we have varices, large varices are much more likely to bleed than small varices because there's much higher pressure in these large varices. So this is what happens when you have an acute variceal hemorrhage. So this balloon pops. And so when we go down and look endoscopically, when somebody has a variceal hemorrhage, there's a big hole in that varice and blood is pouring out under high pressure. Okay? And so that's why it's so dramatic when somebody has a variceal bleed, because it's a high balloon under pressure and it pops and then all the blood starts to pour out. And this makes people very unwell. They can be vomiting up blood, passing black stool, and they typically would end up in the hospital. So how do we treat this? Well, we want to make sure that we resuscitate people. So we bring them in through the emergency room. We typically give them IV fluids. We will give them blood as well. But the concept here is if we give too much blood, we're going to make the pressure in the varices high. And the whole point of this is to lower the pressure in those veins to stop the bleeding. So that's why when we see somebody who's having a variceal bleed, we sometimes don't necessarily give blood transfusions right away because we don't want to increase the pressure. What we do is we give medications through the IV in order to lower the pressure in those veins. And so you may have heard of medications such as octreotide or terlipressin. Those are medications that we give intravenously, and what they do is they lower the pressure in the portal venous system to try and stop the bleeding of the veins. Then what we would typically do is we would go down with our endoscope and we would put elastic bands around these bleeding varices to stop them from bleeding. That works, I would say, probably 90% of the time. But there are certain individuals who come in with bleeding where, despite all of our best efforts, the bleeding continues. And that's where we start talking about what we call salvage therapy, or things that we need to do in order to stop the bleeding. Two things that we would use would be a Blakemore tube, or we can use a transjugular intrahepatic portosystemic shunt, otherwise known as a TIPS. So the way that these work, so this is a picture of a Blakemore tube. So what happens if somebody's having a lot of bleeding down here at the esophagus? What we do is we insert this tube and we put it all the way down into the stomach. And once it's in the stomach, we inflate a balloon here. And what we do is we pull up on here so that the balloon puts a bunch of pressure right here at the end of the esophagus. And basically what that does is it stops the blood flow from coming up into the varices to try and stop it from bleeding. This is a temporary measure. It's not a permanent measure. Typically what we would do after this would then be to consider whether or not somebody can get a TIPS procedure. So what a TIPS procedure is it's basically creating a bridge over the traffic jam. Okay, so here's the portal vein. The blood's trying to come up through here. This is a liver that has cirrhosis that's all scarred down, so the pressure in this vein is really high. What happens is the radiologists go down from the top in the neck, because remember, the portal blood system is not connected to the rest of your blood system. So what the radiologist needs to do is they need to take a catheter through the neck in your vein, come all the way down into your liver, and then create this bridge from this vein to this vein. And basically what it's doing is it's bypassing all the scarred tissue and all the traffic jam. So once this stent is put in, then all of a sudden there's another path of least resistance for the blood to flow, and therefore the blood starts to flow through that shunt, and then it lowers the pressure in the portal system, and then it can stop the bleeding. Okay, any questions about that? Has anybody here themselves or had a loved one who required a TIPS procedure?
We get questions about that a lot, so we
Yeah.
may have some people in here.
I have had 5 different varices that started bleeding.
Mm-hmm. Yeah. And so what sort of, if you're willing to share, what treatments did you have for your varices?
They just did the banding.
The banding. Okay. So you didn't require kind of going to the next step.
And they put me into a medical coma on one of them.
Okay.
But as far as I know, I think they were all just banded.
They were all banded. Like I said, about 90% of the time we can control it mostly with the banding.
Yep.
Yeah.
Yeah, that was me too.
That was you too? Yeah.
The banding. Yeah.
The banding. Yeah.
Yep.
And then, as you know, after the banding, you have to come back for many sessions to try and get rid of those veins. So our approach is once we control kind of the acute bleeding and everything settles down, we want to get rid of those veins because we know they're at high risk of bleeding again. The other thing that you may have received was a beta blocker. Did anybody get put on a beta blocker? Okay. The way the beta blocker works is it lowers the pressure in this portal vein. So the whole thing, what we're trying to do is to try and treat the pressure in that portal vein. This is really the kind of key thing that's causing all of these problems. And so we use beta blockers because we know it lowers the pressure. If we're really in a tight situation, we can put this TIPS in. But ultimately, if we do a liver transplant and get rid of this roadblock, then the pressure will go away and all those complications will go away. Okay, any other questions about that?
I just want to comment on something that I didn't. I had small varices when I was first diagnosed, even though I had decompensated cirrhosis and I was
Mhm.
really, really sick with every other symptom.
Mhm.
And they were small until 6 years later. And 6 years later, they found large varices. So this
Mhm.
is the importance of your follow-up. So
Mhm.
if you're recompensated like me, know that stuff like this can happen. And
Mhm.
I was like, what did I do wrong? And he's like, you didn't do anything wrong. This is just something that can happen to a certain
Mhm.
percentage of people. So keep up with your appointments, please.
Mhm. Okay, so the next thing I was going to talk about was ascites and how does ascites develop in this situation. So basically, the term ascites, all that means is that there's fluid in the abdomen because there's not supposed to be fluid in the abdomen. And there's many causes of this, but the most common reason why people develop ascites is because they have cirrhosis and portal hypertension. There's other reasons that I've listed there, but if you were a betting person, if you saw somebody for the very first time that had fluid in their belly, chances are they probably have underlying cirrhosis and portal hypertension. So what happens is in the setting of portal hypertension, so remember when we're looking at that microscopic level and we're looking at those tiny sinusoids, the pressure in there is very high. And so what happens is all of a sudden fluid starts to leak out of the liver into the abdomen because the pressure is so high in the liver. And that's really how it happens. And if you talk to surgeons who have ever done any surgeries on somebody who has portal hypertension, they'll tell you that you see fluid dripping off the liver. And basically, it's because that liver has so much pressure inside that the fluid starts to leak out because it's trying to follow the path of least resistance. And that's how ascites develops. So the way that we can figure out why somebody has ascites is doing a paracentesis. I'm sure that some people in here have probably had paracentesis before, where you take a sample of the fluid in your belly. And then what we can do is we can look at that and analyze that and try and figure out, is this because of cirrhosis and portal hypertension? So when we take fluid out of the belly, we send it off for lots of different things. The things that are most important are looking at the protein and the albumin level and looking at the neutrophil count and sending a culture to make sure that it's not infected. This is what we actually do when we're trying to figure out, does somebody have ascites from cirrhosis? We calculate what we call the SAG, or the serum albumin ascites gradient. We check the level of the albumin, which is the main protein that in your body, in the fluid, and then we check the albumin level that's in your blood, and then we subtract it. And if there's a big gradient, then we're pretty sure that it's probably from cirrhosis. I won't go through this in detail, but basically we use this algorithm to say, is this coming from sinusoidal hypertension and cirrhosis? We can figure out if it's coming from other causes as well using that, but this is one of the main ways that we can tell that the fluid in the belly is coming from cirrhosis and portal hypertension. So when somebody develops ascites, as many of you may know, the first thing we do is we suggest salt restriction because water follows salt. The more salt you eat, the more water you retain. So we try and lower that. And we also start people on diuretics or water pills. And typically we would use a combination of two of them. One is Lasix, one is spironolactone to try and get your body to eliminate that fluid by peeing it out. So we usually recommend sodium restriction and the diuretics. Many people, once they develop ascites, they'll respond very well to starting diuretics and salt restriction. But in a certain group of individuals, they will develop what we call refractory ascites. And that's when people have ascites where either we can't use a high enough dose of diuretics to get rid of the fluid because people develop complications such as low sodium or kidney dysfunction, or you're using the maximum doses of medication and you're still not able to control the fluid in the belly. And when somebody develops refractory ascites, that's when we start doing large volume paracentesis or inserting a needle into the belly and draining out liters and liters of fluid in order to get relief. We can also do a TIPS procedure because the whole problem here with ascites is pressure. And so if we want to try and get rid of the ascites, we need to get rid of the pressure. So we can do a TIPS procedure just like we could for variceal hemorrhage, because what that is going to do is lower the pressure. And ultimately, we're thinking at the end of the day, is the liver transplant going to be the best option here? So when somebody develops ascites that we aren't able to control with medications, these are the types of things that we do to help get patients' symptoms under control.
We have a question that goes back to the bleeding varices.
Yeah.
Can a sudden spike in blood pressure cause a bleed even if someone doesn't have high blood pressure?
No, because if you remember, the two blood systems are not connected. So when you check the blood pressure in your arm, you're checking what we call is the systemic blood system. So that's your heart and it goes to your kidneys, everything. Your portal blood system is not attached to that system. And so if you have high blood pressure, it doesn't necessarily mean that there's high pressures in the portal blood system. Does that help clarify?
Possibly. It was someone else's question.
Okay. Oh, sorry about that.
Yes.
Okay. All right. I know we're running a little bit low on time here. So SBP is basically an infection in the ascites fluid that we diagnose based on when we take a sample of that fluid. And the way that that develops is because this is actually a picture of the lining of your gut, okay? So as you may or may not be aware, there's millions and millions of bacteria that live in your bowels. What happens when you have portal hypertension and there's high pressures that are then transmitted back to the gut? What happens is these bacteria go through the gut and they go right into your abdomen. And then those bacteria can grow in the ascites because your immune system is not able to fight infections in there. And so if bacteria get into the ascites fluid, it's a perfect place for it to grow. Okay. And so that's why people with cirrhosis and ascites can develop infections in the ascites fluid. And then this is just about treatment. I won't go into details about that. Hepatorenal syndrome, I wasn't asked specifically to talk about this, but just to say that when you have cirrhosis, ascites, and significant portal hypertension, it can significantly impact your kidney function. And the way that it does that is because when all the pressure is building up in the portal system and all that blood is pooling into your portal system, what happens is that there's not enough blood flow in your systemic blood system to help your kidneys. So basically, it's like your kidneys are not getting enough blood flow because all the blood is stuck in your portal system. And so people can go into kidney failure because of that. It's not because there's something actually wrong with the kidney itself. You could actually take that kidney and transplant it into somebody else and it will work just fine. It's a complication of the high pressures that are in the portal system that the rest of your body's not getting enough blood. Okay. And finally, hepatic encephalopathy, which I'm sure many people have unfortunately had to deal with. How does this develop in this setting? Well, it's very complicated. And this slide is not meant to go through everything, but just to highlight the concept that when your hepatocytes are not functioning properly and there's high pressures that are causing them not to function properly, you're not able to filter out all the waste products and things that your liver normally does. And so what happens, instead of your liver processing it, it gets pumped out to the rest of your body. And when it reaches your brain starts to malfunction. And so typically that can cause confusion, sleepiness, fatigue, all of those symptoms of encephalopathy because the city is starting to fail and it's not able to clean out all of those toxins. So this is a spectrum of encephalopathy. There is something that we call covert encephalopathy. And what that means is that there's dysfunction in the way the brain is working, but it's very hard for us as physicians to detect it because it requires very sophisticated testing to do. When somebody has what we call overt encephalopathy, or over here in this 2, 3, and 4, that's when people start to develop symptoms and they start to notice, or their family members start to notice that they're developing confusion and lethargy. And that's when people develop asterixis. So what asterixis is basically a clinical tool that we use to make a diagnosis of hepatic encephalopathy. So we get people to hold their hands out, pretend you're pushing up against a brick wall. And what we're looking for as clinicians, I'm trying to see if I can get my fingers in here, is this involuntary forward flapping. It's not the side-to-side tremor. We're looking for this involuntary forward flapping. And the reason that's happening is because the individual who's holding their hands up is trying to keep their hands up, but because their brain isn't functioning properly, your brain's letting your hands fall down and then you try and bring it back up. And so this is why you see this flapping. And that's how we make a diagnosis of hepatic encephalopathy. There's lots of things that can precipitate this. Again, I won't go into a lot of details about this, but it can be from medications, it can be from infections, it can be from bleeding. There's lots of different things that can cause hepatic encephalopathy to get worse. So what we usually do is we have to treat whatever caused it. So if somebody comes in with an infection, we treat the infection, we treat their GI bleeding, we treat their kidney dysfunction. And that's when we start using things like lactulose, and we try to titrate to 3 to 4 bowel movements a day, as well as rifaximin, which is an antibiotic. Now, the way that lactulose works is twofold. So first, when your liver can't clear out your toxins, we get you to poop them out. So we just want all the waste product that's in your GI tract to come out quicker so that your body does not absorb those nitrogenous waste products. The other way that it works is, so this is nitrogen. So what happens is if your nitrogen is positive, it stays in the gut. If your nitrogen is not positive, it gets absorbed. So what the lactulose does is it tries to keep all this nitrogen in a positive status so you can poop it out. So that's how the lactulose works. And that's why we're very persistent on trying to get enough lactulose, because what it's doing is it's trying to bind all the toxins and have you poop them out so that they don't get absorbed into your body. Okay. So that was a lot of information. But I hope what I've been able to convey to everybody is what an actual diagnosis of cirrhosis means, what compensated cirrhosis and decompensated cirrhosis means, and how the development of portal hypertension is really the key factor that leads to all these different complications. So I am happy to take questions or comments, clarify anything that wasn't clear when I was presenting it. And thanks again for coming and listening.
Thank you so much, Dr. Flemming. If anybody has questions, if you could raise your hand so that you get pushed up to the front and we can see, and even if your camera isn't on, or if you would like to ask any questions in chat in the next few minutes, please do, and I'll open it up.
Amber has a question in chat. Would blood pressure medication such as, I don't even know how to say that, carvedilol,
Carvedilol?
affect portal hypertension?
Yes. So there's only 3 medications typically that can improve portal hypertension. So carvedilol, nadolol, and propranolol. And the reason is that those blood pressure medications act on the receptors in the portal venous system, whereas all the other blood pressure medications don't. So that's why when we're trying to treat portal hypertension, we have to use those specific medications because they're the only ones that work on the portal blood system.
We have another question. Is there a written description of what you just described?
Sorry,
There was
a little bit of a glitch there.
Is there a written description of what you just described? I believe that was all of the symptoms you were talking about.
Oh,
I'm not sure.
Not really, I don't think. I've kind of developed this in my teaching over time to try and convey this concept. So I kind of came up with it myself. If you're talking about like the city and the houses and the sinusoids and all of that sort of stuff, that's something that I've kind of just developed over time. So it's not specifically written down anywhere.
It could have been about the HE or something else, though.
Yeah, if
But
you could
what exactly do you want to know? It's Holly Hobby's question. Okay. Well, I don't think she's going to answer that.
That's okay.
Okay, Roger said.
Hopefully my response
Okay,
answered
here we go.
answered your question.
It's in here. The terminology and what leads to what condition.
Um, I mean, there's certainly lots of medical reviews that would go through this concept. If you're asking about talking about the concept in more kind of general terms, such as the terms I use, this is just something I've developed myself. Um, there's a website that I refer my patients to very often called cirrhosiscare.ca. And it's a website that has lots of patient-friendly information, videos, explanations. There may be something on there that may be helpful or very similar to this that would be described in kind of patient-friendly language. So
And
I'll put it in the chat.
we
The
also have the
website.
American Liver Foundation talks about a lot of these things, which is a reputable site. And the Mayo Clinic websites also describe things in pretty much layman's terms, easy to understand.
Yeah. So I use lots of car and traffic analogies when I am trying to convey these concepts.
I was going to say I really like the analogy, so it's very helpful for us to understand. Other questions? Is there a chance?
I have a
Talk
question.
after.
So you like to diagnose people by hand flapping. How do you feel about when people say their ammonia level's high, they feel fine? I have always been under the impression that ammonia level is not a very accurate way to diagnose HE because it can be high and you can feel fine, or it can be
Yeah.
low and you can be very symptomatic.
Yeah.
So
Yeah, I had a
do
slide
you
on
prefer
that.
to do it just by symptoms and
Yeah, I never
hand
order an
flapping?
ammonia. I never order ammonia because just for that reason. Some people with cirrhosis can have high ammonia levels but feel perfectly fine. So then why would I be treating a lab value? I'd rather treat the patient in front of me. And so that's why we really kind of listen to the patient, listen to their symptoms, do a physical examination to make the diagnosis and not rely on blood work alone. But I think that that's something that I see very commonly done in people who aren't liver experts, because I think
Mhm.
there's this concept that yes, ammonia equals hepatic encephalopathy, and unfortunately it's not that simple.
That's why I was asking. I know that a lot of doctors don't do
Yeah.
ammonia tests. I
I
never
would
had
say
mine
the
tested.
majority of hepatologists wouldn't unless somebody has acute liver failure, and that's a completely different situation. But somebody with chronic liver disease or chronic liver failure using ammonia levels, I can't even remember the last time I ever checked one.
I saw something in a Facebook group yesterday, and someone said their ammonia level was high and they felt fine. And someone else said, you need to get to the ER immediately because
Yeah.
it's high enough that your brain is going to bleed.
Yeah. No.
And
So yeah. Yeah. That's not how
yeah.
we would approach that sort of situation. And hepatologists generally would never order an ammonia level. The problem with ammonia levels as well is they're supposed to be taken from an arterial blood draw, not a venous blood draw. And most people get all their blood work done as venous. And so we know the levels are not reliable if you take it from the veins. In order to get it from the arteries, that's a completely different procedure. And again, it still doesn't necessarily mean because your ammonia level's high that you have encephalopathy.
Does hepatopulmonary syndrome follow the same kind of like hepatorenal? They all just backed up? Is that what's and
So a
thoracentesis?
hepatopulmonary syndrome is a little bit different. It's about shunting of blood in the lungs, not necessarily. I mean, there's probably some component of portal hypertension which predisposes to that, but getting rid of the portal hypertension won't get rid of the hepatopulmonary syndrome. The hepatopulmonary syndrome is mostly from factors that are released from the liver that act on the blood vessels that are in the lungs. So it's a little bit different.
But the need
Nicole?
for like a thoracentesis, like I mean, I had that
Yes.
and paracentesis is the fluid, again, least resistance. It's now up into the chest cavity,
Yeah.
right? That's then making its
Yeah.
way into the lungs.
Hepatopulmonary syndrome does not cause a fluid buildup and you need
That's right. Yeah.
thoracentesis. What it does is cause your capillaries in your lungs to dilate.
hmm
Your liver will do that, and then the red blood cells shoot through so fast they can't absorb any oxygen.
That's
And they're
right.
floating around in your body and you're not getting the oxygen you need. I had hepatopulmonary syndrome.
Yeah,
That's how
so did
I know
I.
this.
Yeah.
And I was
But
on
what you're talking
oxygen.
about, Nicole, is hepatic hydrothorax. So that's when when it follows the path of least resistance isn't actually to go into the abdomen, it's to go into the lung. Because your liver sits right under your lung, right? So if that fluid is leaking off your liver and the path of least resistance is going through the diaphragm up to the lung, that's where it will go.
Yeah. Okay. That's right.
Yeah.
Thank you.
So getting a TIPS procedure in that instance will help the hydrothorax because it's a pressure problem.
Anybody else have any questions? I had a question real quick to Dr. Flemming and thank you for people that are leaving. Thank you so much for coming. I put a buddy system site into the chat. So if anybody hasn't joined our buddy system and would like the opportunity to be able to call people or be called or either or both, please go to that site. And then Dr. Flemming, I had a doctor that told me recently that there was another test for hepatic encephalopathy that had to do with some sort of, I'm trying to remember what it was. It was like a physical test that you do. Do you know what that is that he's
It
talking
could be pertaining to the covert encephalopathy. So that's the brain changes that can occur from the toxins building up before you develop asterixis. So there's lots of different kind of tests that you can do for that. You can do like animal naming tests. You can do a bunch of different cognitive type of testing in order to make that diagnosis. So they do that a lot in research settings, but it's not as practical to do in kind of everyday practice because it takes a long time to actually do. And we don't really know if we should treat somebody at that stage or not, which is why we don't necessarily always look for it.
Good, good. You just got a very good compliment in here. And Nancy, you can read it because I'm thinking of this other thing anyway.
Well, Marcy said, thank you for making this understandable to a normal person. First time I've heard this info and described so well. And you do have a lot of thank yous from other people who are here in the chat. I don't know if you saw them or not.
Yeah, I'll pull it up. Thank you, everybody.
Yeah, yeah. So we really appreciate you being here. And I just wanted to say to everyone that if you have any other questions that come up for Dr. Flemming, I'm sure that she wouldn't mind if I kind of relay those to her. So please just let me know. And I just wanted to remind everybody too, you can go ahead and stay and we'll talk a little bit. And if Dr. Flemming if there's any more questions for her, she may have to leave us, but I did want to say that we are going to have our reflections period so we can just talk amongst ourselves, which is always a very nice experience, and sharing some stories that have happened during our week. And I really thank everybody for being here. I love these education sessions, Dr. Flemming, because I think they're very, very valuable. As we talked about before you came on, the hepatologist, when you go into your appointments, there's not a lot of time to really try to dig into some of this stuff and really understand it. And we want to make sure you're getting the credible information, like what Nancy brought up about the Facebook group, because there's a lot of misinformation out there, and that's one thing that we always want to clear those things up, and that's why we value having people like Dr. Flemming so much. So thank you so much from I just learned what the bottom of my heart, I was like, where did that come from? And they said, well, it means deeper, so you don't want to say from the top of your heart because that's like the surface level. So yes, but thank you from the bottom of my heart. I really appreciate it. And so if you want to stay with us, you're welcome to. It's up to you. And
yeah, I'm going to get home to my family, but yes, if anybody has any other questions they want to relay through Jen, that's great. And this has been recorded, so you can watch it again to kind of get any points that you missed or share it with other people.
Wonderful. Okay, well, thank you so much. I appreciate it.
All right.
Thank you.